the Senior Research Manager at Solve ME, and previously I was a Research Fellow at the London School of Hygiene and Tropical Medicine with the Cure ME group run by Luis Nicole and Eliana Lacerda. I have been in the ME world since 2018, and previously I conducted research in chronic conditions such as diabetes, hypertension, and obesity. I am not a clinician, but rather an epidemiologist. So today I'll be presenting to you the very early stages of a paper which aims to answer the question, do people with joint hypermobility represent a subgroup of ME/CFS? So we are all well aware of and have heard much throughout this conference that people with ME are a very heterogeneous group. People experience different symptoms, report different triggers of their illness, and progress differently throughout their disease. It is likely that there are meaningful subgroups regarding the different patterns of experience, and this has major implications on research. Where one research group may find significant results, whether that's looking for a biomarker or an effective treatment, another research group may not find anything. It has now been accepted that subgrouping people with ME is paramount for understanding how and why people develop this disease, as well as how to effectively treat them. However, we researchers are still searching for the right methods that can consistently differentiate subgroups. So joint hypermobility, also known as double jointedness, describes one or more joints that can stretch further than normal. It is fairly common and occurs about 10 to 25% of the population, with women affected about 3 times more often than men. Excuse me. For some of these people, particularly athletes and musicians, hypermobility can be an advantage. However, a minority of people develop problematic symptoms. For example, musicians with hypermobile fingers may display superior abilities due to their increased range of motion, or they may have difficulties when their fingers collapse into a locking position. The exact cause of joint hypermobility is not known. However, the disorder tends to run in families, meaning there is some genetic involvement. In rare cases, joint hypermobility is a sign of more serious conditions, such as Ehlers-Danlos syndrome or Marfan syndrome, which are connective tissue disorders and can affect more than just your joints. The Baton score has been used for many years as an indicator of joint hypermobility. It can quickly and easily assess generalized joint hypermobility using a 9-point scale and requires the performance of 5 movements of joints, including the thumb, the spine, the elbow, knee, and the base of the pinky finger. It was originally introduced for epidemiological research, and it is used solely as a clinical resource and screening tool. It is not used to diagnose hypermobility and does not rule out the possibility of specific medical conditions, genetic disorders, or diseases. And it should not be used as a substitute for more in-depth, thorough, and often necessary diagnostic workup or appropriate genetic testing. In the minority of people with joint hypermobility who develop problematic symptoms, the symptoms are multisystemic, meaning they can affect many organ systems in the body. Many of these symptoms are shared with ME. These include severe fatigue and difficulty concentrating, as well as headaches, problems with balance control, which is essential for maintaining an upright posture, as well as for dynamic posture, difficulty regulating blood pressure, which can cause dizziness and fainting, especially when standing, persistent and widespread pain that makes it difficult to sit still or difficult to move, joint and muscle stiffness, gut, bowel, and bladder problems that can lead to either frequent or infrequent use of the toilet, loose joints which can dislocate easily or cause frequent sprains, and skin that is easily bruised or damaged because it is fragile and stretchy, or skin that is easily scarred because it is thick and velvety. So is joint hypermobility associated with an increased risk of developing ME? There are 2 main hypotheses for this connection. As I mentioned previously, joint hypermobility can be a sign of more serious disorders that involve laxity or looseness of connective tissues. Connective tissues are more than just the cartilage that holds your bones together. They are found in between other tissues everywhere in the body, including the nervous and the circulatory systems. When connective tissues of the circulatory system are loose due to a defect in the production of a collagen, arteries can swell or stretch. As a result, upright posture could lead to an increased pooling of blood in the extremities and is characterized by a reddish-purple color of the legs and/or hands upon standing, which in turn leads to the reduced blood flow to the brain. This causes the heart rate to compensate for the blood pooling and cause many of the symptoms that are also seen in people with ME, such as POTS and other dysautonomia symptoms. Another hypothesis is that of craniocervical obstructions in which arteries and veins, both into and out of the brain, are blocked. One reason related to joint hypermobility is that the ligaments in the neck are stretched out so that the head is moving forward from the shoulders. When the head is in this position, the veins are pulled and stretched out, narrowing them. This results in less room for blood flow and fluid to flow in, and a buildup of cerebral spinal fluid in various parts of the brain, including the frontal lobe, which negatively impacts the brain neurons and tissues and can cause symptoms like severe brain fog. If joint hypermobility is a risk factor for ME, we would expect there to be an impact on the age of onset, type of onset, as in gradual versus abrupt, the types of symptoms reported, the presence of coexisting conditions, and the overall health-related quality of life and severity of ME. This project really came from previous research published by Dr. Vogel with Dr. Peter Rowe at Johns Hopkins University, where they examined differences in demographic and clinical characteristics between people with ME meeting the Fukuda criteria who had joint hypermobility and those without joint hypermobility. Joint hypermobility here was defined as those who had a Batten score of at least 4, and about half of their 55 patients met this criteria. They hypothesized that ME patients with joint hypermobility would have an earlier onset of symptoms, an increased severity, a greater number of coexisting conditions, and lower health-related quality of life. But they found no significant differences between the groups and concluded that the paradox required further exploration. So the present research was made possible through the U plus ME registry, which was launched by Solve ME in 2020 and is a collection of patient-reported data. It was co-created with the patient and research community. The U plus ME community is made up of 3 cohorts of participants: people living with ME, people with long COVID, and control volunteers, both healthy and those with short COVID. Participants use a secure web portal to enter self-reported information at baseline and at follow-up time points. They can also download and use the U plus ME mobile app, which gives them the ability to track their symptoms, life events, activity levels, and overall wellness. The data set is made up of over 2 million data points of real-world survey and symptom tracking data. Researchers of diagnostics and treatments can access de-identified data after a thorough review process. Their findings are then shared with the patient and research communities. As of February of this year, we have nearly 3,500 people with self-reported ME in our registry. Our motivation for the present study was to try to replicate that previous study using the registry with its much larger sample size. We included 687 patients with participants, with ME who met either the Fukuda or the Canadian consensus criteria and were above the age of 18, with a mean of 50 years for age. Here we define joint hypermobility as having a Batten score of at least 5 if they were under 50 years old and at least 4 if they were over 50. In our cohort, only 12% met this criteria. However, this is closer to the overall prevalence of about 10% with joint hypermobility in the United States. Our hypothesis was the same as that of the previous research, hoping that we would be able to find more significant results that could lead to targeted treatment for those individuals with joint hypermobility that would have a beneficial impact on their health-related quality of life. Using the same statistical methods, well, for now, we will be using more for sure. We had the following results so far. Similar to the previous study, in that we found no statistically significant differences between the groups for many demographic and clinical characteristics. You'll see here, but I will save time by not reading them out. However, we did find some statistically significant differences. We found that people with ME and joint hypermobility had significantly higher percentage of self-reported Ehlers-Danlos syndrome and a family history of the disease. This is to be expected due to the genetic nature. However, interestingly, we found that this group also had statistically significant higher levels of self-reported POTS and higher levels of the symptoms of loss of balance, unsteadiness on feet when standing, or inability to focus, vision. This gives some evidence for the first hypothesis that I talked about, in which the connection between joint hypermobility and ME could be due to connective tissue looseness in the circulatory system. We also found some differences, although not statistically significant, for severity according to the Karnofsky Performance Scale when categorized as mild and moderate and severe, very severe impairment, as well as the number of reported autonomic symptoms, dizziness or faintness while standing, intolerance to standing, and joint pains moving to different joints without redness or swelling. As I said, we are presenting the very early stages of this project, and so we'll use these findings to drive the rest of our analyses. As with any research, interpretation of these findings has some limitations. Firstly, is the use of the Baton score, which only looks at select group of joints and has the potential to miss clinically meaningful hypermobility. You'll notice that 4% of those self-reporting Ehlers-Danlos syndrome did not meet our criteria for joint hypermobility. So something interesting there. Other limitations are related to the registry itself, which include the self-reported nature of the data. This can produce measurement error due to participant recall, interpretation, or other factors. And there is potential for selection bias, including sociodemographics, selective patient drop-off, and missing data. Unfortunately, these are frequent concerns in registry-based research and can introduce issues with data accuracy, interpretation, and generalizability. We hope that findings from this current research, once completed and published, will influence future research, which should involve data collection beyond self-reported data, including objective measures such as in-depth and thorough diagnostic workup or appropriate genetic testing to diagnose people with joint hypermobility or connective tissue disorders, and in-depth measures of POTS, heart rate variability, and blood flow to the brain. Lauren Stiles gave a great presentation yesterday, and other researchers have also presented on excellent ways in which these can be done. I want to say a big thank you to everyone at SolveME and an even bigger thank you to the participants of the UME registry.
Thank you. Okay, we have time for some questions here. So let's start with Dr. Beranek. And the question was, does elevated carnitine and phosphoglycerides signal a defect in beta oxidation of fatty acids in the mitochondria of in ME/CFS? We can't hear you yet, Jim. Can you unmute?
Okay, so the physiology of the carnitines is to carry the fats from the cell cytosol into the peroxisome into the mitochondria. So they're an intermediate. Anything that will disrupt that system will interrupt the metabolism of the fats. And the metabolism of the fats is going to be the beta oxidation system. It has some other names as well, but the interesting point is we're seeing acetylcarnitine may be decreased in the plasma, maybe decreased in the urine, maybe increased in the cerebrospinal fluid. What's important there is partly the direction, but also the fact that it's different from control. It may be different from with provocation as well. That will indicate that the physiology isn't working properly, either at the baseline, your usual day-to-day self, or if you have exercise or something else that would be a PEM-like state, you don't have enough of this acetylcarnitine in the cell to do its job of producing energy. Another issue, though, is these fats are supposed to stay in the cells and in the membranes. So if we're picking them up at abnormal levels in the blood, the urine, the cerebrospinal fluid, then you have to ask the question of where are they coming from and why? Is there something about the membranes that aren't working properly? Are cells being chopped up, losing membrane as exosomes or some other type of mechanism? I think it opens a lot of questions. One of the other things is other diseases can have changes in acetylcarnitine and the other markers we found. I think it's important to look for similarities in diseases like cancer, other energy problems, chronic inflammation, to try to look for some of these mechanisms that are similar to other diseases, so that we can look for those, because that helps us to determine if a biomarker is going to be selective just for ME, or is it going to detect a general class of diseases with an energy problem. I think that it's kind of tough for us right now to go to just get the research funds to be able to do these studies and find it in ME. But when we do, I think we have to take a look at the databases that are online in order to see, do we have changes that are similar to other reported illnesses? Somebody mentioned including illness controls in studies. I think that there's going to be a place for that, definitely, as we move to try to define which of these biomarkers are selective for ME, as opposed to other diseases in this category. Thank you.
Great. Thank you. That's excellent work. Okay, let's look at Dr. Peterson. I saw a question here. Let's see. Oh, hold on a second. It was right up here. It said, have you considered the interactions with the healthcare system can contribute to suicidal ideation and execution? There is very little support for ME/CFS in healthcare, compounded by medical gaslighting, because HCP do not understand ME is real.
Well, that's a great question. And it's not just ME, it's POTS. We're struggling with the same thing. So I live more in the POTS world, but my daughter actually has both of those disorders. Yeah, I do think that that's a big issue. Gaslighting and just not being believed by the practitioners who are supposed to be helping us is really traumatizing. And I don't know that I've seen a ton of research on this, but Standing Up to POTS runs a podcast, and our counselor has actually talked about medical trauma and how that affects the family and the individual, and also the effect of gaslighting on there. So I do think that it can increase perceived burdensomeness. It increases hopelessness. If you feel like the people that you are paying to help you, who are supposed to be there to guide you on this medical journey, just aren't getting it. And in that case, what I would say, maybe more as a parent, move on, right? We had someone that tried to diagnose my daughter with conversion disorder. She was 10 and she was clearly ill. I mean, the child could barely move. And I'm like, you know, my daughter was upset and I said, don't worry about it. We're never going back to that doctor again. Right. So just move on until you find someone who really listens and pays attention. It's
Great,
difficult.
thank you. Yeah, I agree. I think that part of the healing process as clinicians is just listening to the patient and believing their story, that it can start healing them from the trauma that they've experienced before they've walked in our office. Thank you. Okay, Kathleen, your question was, we see many patients with ME/CFS having striae gravida, stretch marks, when they are not obese and haven't been pregnant. Striae are due to subcutaneous collagen damage. I would be interested if your members who have hypermobility and ME/CFS have abnormal stretch marks, usually on thighs and breast tissue. Interestingly, this is long before the ME/CFS symptoms. This could help us understand the underlying characteristics of collagen damage, connective tissue in both conditions. Your thoughts?
I think this is a really great question, and not an observation that I've heard of before, actually. So it's certainly not a question that we currently ask our participants, but the good thing about having the registry is that we can push questions out for things like that. So if we feel the need as we're going through these analyses to have some further inquiries with our participants, for sure this would be something that we would push out to them. I would certainly ask an expert exactly what does that mean in terms of the connection between, and how we can use that in our analyses as well before doing that. So thank you for the question and the idea.
Great, thank you. Okay, let's see what else we have here. All right. So you've already answered this, Dr. Baranik, but in terms of ME/CFS and Gulf War illness, do you think they're the same illness? Are they sister illnesses?
So Gulf War illness is a neurotoxic condition that occurred in a cohort that were in the Persian Gulf, 1990, 1991. Were exposed to sarin nerve agent, to organophosphates, other pesticides. It appears that 1/3 of them got sick. That third appears to have a genetic predisposition in the detoxifying enzyme peroxidase that may have predisposed them to have more neurotoxicity from their exposures. The other 2/3 came back and have done perfectly well. Can't understand why anybody could be sick like that, and they must be making it up. So it's a very, very regrettable situation that you're all familiar with. Chronic fatigue syndrome, as we've discussed, is attributed to infection historically. When you look at the overlap with fibromyalgia, they will tell you that there's a lot of people that can have motor vehicle accidents, broken limbs, often people that are compulsive exercisers or whatever, they have the restraint stress of being in hospital, and then they develop fibromyalgia. A point I keep bringing up is, what is fibromyalgia? We sometimes hear that we're going to exclude it from a research study. Many patients say they have both. The question is, you have to look at the diagnostic criteria. In that condition, fibromyalgia is pain and tenderness. You can press and cause pain. The difficulty is that in 2010 to 2016, the American College of Rheumatology changed their criteria for fibromyalgia. So now you have to have pain for fibromyalgia, but also fatigue, cognitive problems, unrefreshing sleep. And I'm sorry, but isn't that looking pretty much like the Fukuda criteria for chronic fatigue syndrome? And it's not necessary to show the sign of tenderness. That sign of tenderness is very important because it is now appreciated that if you can press on somebody and they're very, very sore, very painful, that tenderness is due to changes in the spinal cord, in the back of the spinal cord, and changes in the brainstem. In the brainstem, you have a system that responds to activation, to threats, such as pain. And it sends a signal down to the lower brainstem and the spinal cord to try to shut that pain off. That switch, however, is now thought to be broken. And if that switch is broken, then you get pain. That switch, in a study we published in January, I think is in the dorsal midbrain, where we showed an abnormality when chronic fatigue syndrome compared to Gulf War illness patients did exercise and then had an MRI while they were doing a cognitive scan. And in the dorsal midbrain, the two groups show a significant difference from each other. The important thing is that they show a difference, and it's in this one particular area that is fundamentally important for keeping you alive. It's the center that receives all of your threat signals and then decides, is this a buddy, a baby, or a bully? Is this a predator? Or am I prey? Is this a predator or a prey? And those are decisions that are made in fractions of seconds through this brainstem region. Dysfunction there, I believe, is contributing to the PTSD in the Gulf War illness patients, is contributing to the anxiety that is mislabeled as depression in chronic fatigue syndrome, and is also contributing to the sleep dysfunction and the inability to recruit systems that improve your cognition. When we talk about the metabolomics, talk about autoimmune disease, talk about small fiber neuropathy and what may cause them, all of those mechanisms can contribute to this one area or to the entire brain. And any one of those, I'm agnostic as to which one's more important, but I think this part of the brain is critically important in the symptoms that we have and the symptoms that occur in so many other diseases that have chronic sickness behaviors. I think that that's important when we look at the other speakers this afternoon, where we've got, we're starting to draw Venn diagrams from an epidemiological perspective of who has disability, fatigue, sleep upset, cognitive problems, and post-exertional malaise, plus or minus orthostatic intolerance, plus or minus the cognitive problems. I think we can become more sophisticated in splitting these groups up and lumping people together by mechanism, as well as splitting them apart based on symptoms.
Thank you. Oh, you made such great points. We could discuss them all day. I want to thank this panel and all the speakers and presenters today. It has been just another fascinating day as we try to find some answers to this disease. So thank you so much. I'd like to just make a couple of quick announcements. Tomorrow, you'll come back into the auditorium and you'll log into Zoom. If you forget how to do that, like I normally do, you could text your friend or just press X, okay? And then Gather will be open for 24 hours. You can view the posters and you can also meet up with other colleagues or attendees. So thank you again for joining us today, and I look forward to our presentations tomorrow. Have a good evening.